All right, so this chapter will provide the healthcare administrator the foundational knowledge necessary to manage in the post-acute network, especially in the primary care office and the accountable care organization. On page 254, it talks about reinsurance. The goal of these programs was to first provide individual consumers with insurance coverage that is affordable and eliminate any incentives that an insurance company would have to turn down coverage for any individual. Second, to normalize premiums. That page goes on to say, now the goal is to have a process in place that will help insurance carriers provide coverage to individuals with pre-existing conditions that in some instances result in higher cost of care for the carrier. So they're trying to find balance. They're trying to find balance for consumers and the insurance companies. And the goal is to stabilize premiums. The next page talks about risk adjustment history. The DRG payment model is for a single admission or occurrence, and the risk adjustment payment is one that is paid for a year at a time. There's a lot to this little section, but by providing risk adjusted payment, CMS can make more accurate and appropriate payments for beneficiaries with differences in expected costs. So it's all about cost, expected costs, trying to guess what costs are going to be. That way they can plan ahead. This little section talks about risk pools, risk scores, Medicare Advantage. Page 256, we go into risk adjustment data submission. This one ensures the Medicare Advantage organizations, the first list there, the number one paragraph says it must ensure the accuracy and integrity of data submitted to CMS to ensure that all diagnosis codes that are submitted must be documented in the medical record and must result from face-to-face visits. That is important to know. Risk adjustment model overview. In that paragraph, the result is that CMS will get bids that are standardized and that reflect the average beneficiary and the ability to compare bids between different populations with different health conditions. So again, still trying to just, do their best to predict what the cost is going to be, but there's adjustments that are allowed. According to the CMS Managed Care Manual, 9 characteristics help shape the HCC model, from looking at specific diseases to working with perspective fashion, considering demographics and diagnostic testing. So in a perspective fashion, that again is they're looking ahead, they're guessing. And then there's those 9 different paragraphs. I'm not reading those to y'all. Page 257, bottom right, setting of payments for the HCC risk adjustment model. Model started in 2004 and has since been recalculated and revised. And it has been recalculated and revised since the publishing of this book. So continual change. When you do find yourself working in this arena, it is completely it's your responsibility to stay on top of the most recent expectations. Table 15.1 on page 258 to 259. These are HCC codes and descriptions. I would not say you have to memorize these, but you would definitely going to want to know where to find these if you were to need them. Page 260, risk adjustment models for CMS HCC. In order for CMS to calculate risk scores for the aged and disabled beneficiaries, CMS uses a risk adjustment model to accomplish this and for the actual bidding and payment for parts A, B, and C of the program. Keep going, page 261, demographic factors influencing risk scores. Oh, let me back up. On page 261, in the middle of the left-hand column, for other areas outside the long-term model, payment is based on the prior year activity. So I want to make sure you understand that. The first thing I read was that they use the risk adjustment model to accomplish by bidding and payment for the ABC program. And then it goes on to talk about minimum of 90 days, the minimum data set. But the areas outside the long-term model, payment is based on prior year's activity. I've got that underlined. Okay, back to demographics or factors influencing risk scores 1 through 5 there. It's important: the age, the sex, disability status, original reason for the entitlement, Medicare entitlement, and then Medicaid eligibility. An example of payment calculation is as follows. And again, that is an example on the bottom of page 261. I'm not going to read that to you guys. It can be a little bit confusing. I've had to slow down a couple times in this chapter and make sure I knew what I was reading. Page 262, risk adjustment with Medicaid factor. Medicaid factor, for it to be included in the calculations, the beneficiary must be eligible for at least 1 month or more during the data collection year. Then disease hierarchy is mentioned. There's multiple codes inside each of those HCC categories and have diagnoses. Clinically related, ultimately ranked on cost. Keep on moving. Disease and disabled interactions. Disabled interactions are times that two certain diseases and disabled status for an enrollee can increase medical costs. So there are calculations that, or models, if you will, that can give a risk score for those type of people because they do exist. In fact, there are many people who have multiple disabilities and multiple chronic conditions, so their risk score goes really, really high. All right, end-stage renal disease. We've seen that before. That is very important for Medicaid, Medicare. Page 264, we get into the prescription drug with HCC. I'll let you guys read that on your own. And then adjustments again. LTI is based on the payment year, not the data collection year. And CMS will make the payment for the enrollee. So just try to keep these different quirks or nuances about the adjustments, whether you have to make flashcards and put it in Quizlet. I don't want you to get them mixed up. They're all a little different. Comparison of the CMS HCC model when it comes to the prescription model. I'll let you read that. Frailty adjustments. So it's better to identify the future expenditures based on the measurement of items such as demographics, diagnoses, etc. The frailty adjustment is designed to better identify future Medicare costs. So again, they're trying to normalize or stabilize what they think they're going to spend and what's an expected price for certain services for special populations. The normalization of this data or developing a trend creates an opportunity to look at data and trends such as recent coding trends, all the while looking at smoothing out the data over the period of time that is measured. And I forgot to mention the name of that, or the title of that paragraph is normalization factor. Keep going on page 267. 5 areas of required data elements. So the first requirement is the health insurance claim number. The second is the ICD-10 coding. Third and fourth data elements are the service from date and the service to date that identify the dates that the beneficiary received treatment from a provider, such as a physician or medical facility for inpatient care. The last data element is the provider type. Very important to know what the provider type was. Unaccepted sources of data, any kind of diagnostic radiology claim information, that's not acceptable. The reason for this is that radiology reports do not document diagnoses that are confirmed, as this will come from the referring physician who will make the appropriate documentation. Another area is an excluded provider who are not permitted to see the patients. So keep that in mind too. All right, 268, there's a list there. Identification of acceptable facilities, identification of physician types. So table 15.4 on pages 268 and 269, they describe many specialties and different physician specialty types, I should say, and the different codes that go along with those. Last page in this chapter, 270, ICD-9-10 coding for HCC. The valid coding source is the ICD-10. I think I said ICD-9. Let me repeat that. The valid coding source is the ICD-10, codes that are current for the fiscal year that the patient receives services from the hospital. It did used to be ICD-9. Then it was, before that, ICD-8, of course. So again, so much changes in healthcare, and this course, even this chapter, what we're going through in this book is just basic foundations. So please don't expect to, maybe by the time you arrive in your healthcare facility, doctor's office, inpatient, outpatient, it might be ICD-12, ICD-13. So just brace yourself for the different changes. In conclusion, we can see from the chapter, HCC is something that is not new to the CMS prospective payment model. Implementation of risk adjustment models is used to calculate risk. Again, they want to lower risk and save money. That is the ultimate goal, but while still providing excellent outcomes. Hope you all have a great week. I'm here. Message me with any questions.